Hello, welcome to lecture on Chapter 28, Management of Patients with Structural and Infectious and Inflammatory Cardiac Disorders. Today we're going to be talking about valves and valve disease and treatment of such. So here we go. Alright, objectives for Chapter 28: to define various valvular disorders, describe the pathophysiology, manifestations, and management of patients that have them. We're going to discuss valve replacement procedures, how to treat valvular problems, and the nursing care related to valve replacement. We are going to talk about the pathophysiology, manifestations, and patient management of cardiomyopathies, and then pathophysiology, clinical manifestations, and management of patients with infections in the heart. Alright, so we'll start with valvular disorders. There are two main types of valve disorders that we're going to talk about: regurgitation and stenosis. Okay? So as we go into, going to be talking a lot about your valves in terms of a gait. So if you will think about or relate the valves of the heart, their mechanism, their working function as like a fence gate. Okay, it'll help you. Hopefully, it'll help you understand. Regurgitation is when the valve or the gate doesn't close properly, and it allows blood to backflow. You know, blood can go forward the way it's supposed to, but the gate doesn't shut behind it, and so it allows that blood to kind of backflow back into the chamber that it was coming from. So regurgitation is like a gate that's too loose. It just doesn't close properly. It doesn't seal. It doesn't give a good seal to prevent the blood from flowing backwards. Stenosis is when the valve doesn't open completely. It's a stenotic valve is equivalent to an old rusty gate that won't open or won't close. It's kind of just stuck. You might could move it a little bit. You know, you might could move it an inch or two one way or the other, but you can never get it fully open and you can never get it fully closed. So in the case of the valve, that means that blood flow is reduced or it's restricted. The blood can't, that volume of blood that we would normally flow through that valve is restricted and it can't get through. So those are the two main types of valvular disorders that we're going to talk about today. Okay. A third type that we are going to mention is valve prolapse, and that's where the leaflets of the valves actually just stretch a little bit, and they don't. It's not full regurgitation, but it's when those leaflets stretch backward into the atrium during diastole, or I'm sorry, during systole. That should be systole, not diastole on your slide. So it's just a little bit of a stretch. It's a little bit of a give, okay? Typically, mitral valve prolapse it's the mitral valve is what's involved with mitral valve with valvular prolapse. So the stretch would be back into the left atrium from the left ventricle during systole. With mitral valve prolapse, one or more of the leaflets of the valve are involved. Typically, it is asymptomatic, but it can produce symptoms: fatigue, shortness of breath, chest pain, palpitations, anxiety. Having all those symptoms certainly produces anxiety. And then the palpitations also can produce a little anxiety. The chest pain is not correlated with activity. The shortness of breath, palpitations, fatigue, none of that is correlated with rest or activity level. So it's not that typical classic chest pain that gets worse with activity and then gets better with rest. The shortness of breath doesn't necessarily get better with when the patient rests. So, it's just that vague complaint of those symptoms unrelated to rest and activity. It is more common in women than in men. Not really sure why that is. Some people think that it's related to estrogen, the presence of estrogen, but there's really not any proof of that. But it is a much more common thing in women than men. Diagnostics, the way we would diagnose this, or how it's found through physical assessment, presentation of symptoms, just the patient's report of how they feel. And sometimes you can hear a mitral click. Not always. Maybe rarely heard. And in some cases, that's the only sign that you do hear. Sometimes patients are not that symptomatic, so it's kind of a vague thing. And then the definitive test is an echo to look at heart function, to look at the chamber size, and look at those leaflets and see are they actually prolapsing backwards into the left atrium. Medical management is just symptom control, so would be rest, proper hydration, and then reduction of anything that's a stimulant, alcohol, caffeine, smoking, anything that's going to increase the heart rate. Would definitely want to do some teaching about avoiding those things. It is thought, again, there's very little proof of this, but it is thought that people who are not hydrated adequately and maybe who are tired, who haven't had enough sleep, that sort of makes symptoms worse. So welcome to nursing school. If you have mitral valve prolapse, if it's known mitral valve prolapse, you're probably tired, you're probably dehydrated, and a lot of people, a lot of coffee, a lot of cigarettes. So keep that in mind if you have mitral valve prolapse. Other treatments for very severe people: nitroglycerin for the chest pain, calcium channel blockers, and beta blockers. Beta blockers really tend to be the most prescribed, but calcium channel blockers can as well be used for people who don't tolerate beta blockers, but they slow down the heart rate. So that really helps to treat those palpitations and kind of slow down the heart rate, which will in turn help the anxiety as well. Nursing management is all related to education. There is a it's hereditary, so if mom had it or aunt had it or your sisters have it or your brother has it, then it is probably a higher probability that you will get it too. Or if you have it, then there's a very high probability that a first-degree relative of yours will have it as well. So it does tend to be hereditary and familial. There is a risk for infection, endocarditis. Patients with mitral valve prolapse should avoid things like piercings and tattoos, and they should have prophylactic antibiotics before surgery, before dental work. Anything that's going to go below the gum line, they should take prophylactic antibiotics because there is the risk of developing endocarditis from mitral valve prolapse. They need to be aware of signs and symptoms that should be reported, which means that they've got to know the typical typical symptoms that they might experience, and then when do those get out of hand and they need to go seek help. So that's kind of differentiating between what's normal and acceptable and then what's going to not be okay. They need to be educated on dietary changes, lifestyle changes, smoking cessation, reduction of alcohol, rest, proper hydration, stress reduction, and then of course teaching on medications, that they're taking to help control the symptoms. if they're having arrhythmias, if they're having chest pain, you know, they've got to take their medicine, and just all that teaching that goes into medications that they might be taking. All right, the next thing we're going to talk about is mitral valve regurgitation. So again, if you think of regurgitation as that gate that's just floppy, it swings freely almost. It'll close, but it won't stay closed. Okay, so with mitral valve regurgitation, it is the leaflets of the mitral valve that don't completely close, and it allows blood to flow backwards from the left ventricle into the left atrium during systole. So if you remember, during systole, that's the contracting of the ventricles, those valves should be closed. There should be no blood going into the atria. Okay? It should be ventricular pump. And the pressure inside the left ventricle especially, because we're talking about the mitral valve, so you need to know your anatomy, but the pressure inside the left ventricle is very high, obviously. So if those leaflets in the mitral valve are weak, or if they don't close all the way, then the pressure inside the left ventricle forces blood not only out through the aorta, but backwards into the left atrium. So we're actually overfilling the left atrium, okay? Can be caused from degeneration of the valve, of the structures. That could be from mitral valve prolapse. It can be from a cardiomyopathy. It can be from infection. It can be from diseases like lupus or ischemic disease, heart attack. And then in third world countries, the most common cause of mitral valve regurg is rheumatic heart disease. Okay? So eventually, as this backward flow of blood happens from the left ventricle to the left atrium, okay, as that backward flow of blood occurs over and over and over with each heartbeat, eventually it leads to left atrial enlargement. And then even beyond that, it'll lead to left atrial hypertrophy, where the walls of that chamber get very stiff. Okay, and once the left atrium becomes enlarged and hypertrophied, that causes everything to back up into the lungs and causes pulmonary congestion, okay, which eventually, if not treated, leads to right-sided heart failure. So you see how it's kind of a domino effect. The left ventricle is doing what it's supposed to do, but the valve, the gate, won't close. So blood is escaping out of the left ventricle, and instead of going forward through the aorta, it goes backwards into the left atrium. Well, as that's occurring, it's overfilling that left atrium. It's causing enlargement. That left atrial chamber has to enlarge to accommodate the blood that's supposed to be in it, as well as the blood that has escaped from the left ventricle. So it just stretches, it enlarges to accommodate for the extra blood volume. Well, over time, over years, that enlargement, the left atria will become permanently distended, permanently enlarged. Well, it also, the left atria, has to not only enlarge to accommodate that volume, but it has to squeeze harder to pump it out the next time, the next beat. So over time, not only does it enlarge, but the muscle becomes hypertrophied or stiff because it's had to work harder. It's had to pump against more volume. So, and then of course, enlargement and hypertrophy, like I said, eventually that backs up because once it becomes hypertrophied, it's very stiff and it can't pump effectively. So that is actually a reduction of ejection fraction, a reduction in pump function. It causes the blood to back up into the pulmonary system, causing pulmonary congestion. And then once it causes congestion in the lungs, then it leads to congestion or back up to the right side of the heart and leads to right-sided heart failure. So how do we assess for mitral valve regurg? Very, very often this is an asymptomatic, it is a chronic problem that is asymptomatic, so it goes unnoticed. Okay? Typically, it will go unnoticed until very severe right-sided heart failure develops. And then they get the symptoms, all of those symptoms of right-sided heart failure. So go back and brush up on those, the difference between right-sided heart failure, left-sided heart failure. Okay? So right-sided heart failure is going to be our fluid retention, dyspnea, fatigue, shortness of breath with exertion, pulmonary congestion, cough. Okay? So like I said, very often the patient doesn't even know there's an issue until they develop signs of CHF. Okay? Sometimes with an acute onset, it can be from an MI, but often, most likely it's a very chronic thing. Okay? There can be a systolic murmur, a very high-pitched blowing sound at the apex of the heart, systolic murmur, and then irregular pulse is also possible. Okay? Definitive test is the echo. Echo is going to be the definitive test for all of these valve disorders because we have to actually visualize that valve. Okay? So echo is the diagnostic test of choice. We can do a regular echo, transthoracic, or a TEE. So go back and brush up on, remember what a TEE is and why is it better than traditional echo. Medical management is care of the CHF. Okay, we're going to do the same thing for this valve problem, which really we're not treating the valve. Really what we're doing is treating the CHF. So we're doing medical management for CHF. So afterload reduction, okay, ACE inhibitors, ARBs, beta blockers, all the same medicines we would use for afterload reduction, and then activity restriction just to help control symptoms. Of course, the more symptomatic they are, the less, the more they need to balance activities and rest. The surgical intervention for the valve is a valve replacement. Okay, the book talks about valve repair and valve replacement. We are only going to talk about replacement, but there are some procedures where they can go in and just do resect part of the valve, or maybe tighten up some leaflets that are loose. So surgical intervention is necessary to repair the valve. If repair is not possible, then replacement is indicated. Okay, mitral stenosis is the next disorder we're going to talk about. Remember, stenosis is that rusty gate. You might can budge it a little bit one way or the other, but it won't completely close and it won't fully open. So we've got a narrowed or restricted passage that blood is trying to move through. Okay? So it's an obstruction of blood flow from the left atrium into the left ventricle. Most of the times, mitral stenosis comes from rheumatic heart disease, endocarditis. It's classified or characterized by thickened leaflets, thickened chordae. They can actually fuse together in some places. So it actually ends up being just like an old rusty gate that you cannot push it completely open and you can't push it completely closed. Okay? Basically, it just kind of, they fuse and they just get stuck, and so there's very restricted movement of blood. It results in poor left ventricular filling, which leads to decreased cardiac output. It also causes the blood to back up into the left atria because it can't completely empty out of the left atria. Because there is that resistance that to the valve is stuck and the blood cannot move through it, the left atria actually ends up having to pump harder. And so we get into that same situation as with regurg, where the left atria will dilate to accommodate the extra blood. And then over time, that muscle, the left atrial chamber, will hypertrophy and get thick and stiff from overuse. Okay? Hypertrophy is like going, if you were to go to the gym and work out very intensely and just overwork your muscles and they become very hard and stiff, not the good being in shape, but the overworked, it eventually becomes bad for your muscles. And that's what happens to the heart. It just gets very hard and stiff and thick. That's what hypertrophy is. So blood, can't get into the left ventricle, so it backs up into the left atria. The left atria initially will dilate to accommodate the extra blood flow, and then over time, as it has to continually pump against that pressure, it will hypertrophy and get thick and stiff. And here again, eventually, that hypertrophied chamber leads to pulmonary congestion, which in turn eventually leads to right ventricular failure. Okay? So our symptoms, typically for mitral stenosis, the patient becomes symptomatic when the valve is restricted by a third to a half of its normal size. So again, initially it can be asymptomatic until there is fairly significant impairment of that valve. Okay? Dyspnea on exertion is the first symptom, and that is typically because of the venous congestion and pulmonary hypertension. With pulmonary congestion, with that hypertrophied left atria that backs up into the lungs, all of that pulmonary congestion will cause pulmonary hypertension. And that dyspnea on exertion is one of the first symptoms that the patient will have. Fatigue, again, coughing, wheezing, pulmonary manifestations, of course, with pulmonary congestion. AFib is very common, atrial dysrhythmia, or AFib, and that is as the process, as that dilation and hypertrophy progresses, then that stiffened, thick atria produces abnormal rhythms. So that's where the AFib will come from. And then also there can be a diastolic murmur that can be auscultated. Again, we're diagnosing with echo, either traditional or TEE, and then Doppler flow studies. They will use the Doppler flow study with an echo to see how much blood is actually being able to move through that valve opening. EKG and then heart cath are going to be used to determine the extent of the stenosis. How severely is that valve restricted? And then how much damage is there in the left atrium? Medical management, treatment of CHF, just like before. So treatment of CHF, and then if they have problems with AFib, it's antiarrhythmics to treat the AFib. Okay? And then, of course, as you probably remember from last semester, anybody who is in AFib needs an anticoagulant to reduce the risk of clot formation and embolus. So you're looking at afterload reducers, antiarrhythmics, and anticoagulants. Activity restrictions, you want these people to avoid strenuous activities. Anything that makes the heart rate go up is going to cause the cardiac output to drop, because as the heart rate increases, that left atrium cannot keep up with the demand, and so cardiac output will fall. Surgical intervention is it's called valvuloplasty or commissurotomy, where they go in and try to open up those stenotic leaflets. Sometimes that cannot be done, and so valve replacement is the next indicated procedure. Aortic regurg. Aortic regurgitation. Backwards flow, again, just as we talked about mitral valve regurgitation, here we're talking about atrial or aortic, I'm sorry, not atrial, aortic regurgitation. So again, it's that loose gate. It's that loose, incompetent valve that doesn't close all the way, and instead of, backflowing from the left ventricle to the left atrium, as with mitral regurg, we're talking about blood flow from the aortic valve. It should be going into the aorta, but it's not. It's backflowing into the left ventricle. Okay? So it's backflow of blood into the left ventricle during diastole. Okay? And now if you think about it, diastole should be the filling time, right? So here we get this conflict. We get this backward flow of blood. It should be going out into systemic circulation. But as that left ventricle fills up with blood from the left atrium, we also are getting an influx of blood through the aortic valve in a backwards motion, so it's an overfilling of that left ventricle. It's just the same concept that we talked about a minute ago with the left atria being overfilled. Okay? It's just this time, instead of it being the left atrium, it's the left ventricle. Causes can be inflammatory changes, rheumatic heart disease, congenital problems, chest trauma, an aneurysm. There can be idiopathic degeneration of the valve for some reason. There's all kinds of things that could cause these leaflets to not properly close, okay? But it's that incompetent valve, those leaflets, that gate, it just, either it doesn't close all the way or it's just floppy. And so it won't, when it closes, it doesn't hold. In either case, whatever the cause, it leads to left ventricular dilation and hypertrophy, because that left ventricle has to enlarge to accommodate that extra blood. And then it becomes thick from the increased pressure trying to pump out all of that extra blood. Okay? So we end up with this big, dilated, big, enlarged, stiff chamber. Okay? It's just a big, fat, stiff ventricle. Okay? And what does that mean? It doesn't contract like it's supposed to. So left ventricular hypertrophy will eventually back up into the left atria, and that will lead to left atrial dilation and hypertrophy, which eventually backs up into the lungs. Okay, so left ventricular dilation and hypertrophy, left ventricular hypertrophy, left heart failure. Okay, that's what we're looking at here. Assessment findings, typically, again, asymptomatic. Sometimes the patient will tell you they feel like that their heart is beating very hard in their head and in their neck, and you might be able to see visible pulsations sometimes, but not always. Typically asymptomatic until they develop heart failure symptoms. Okay? So what are our left side, left heart failure signs and symptoms? dyspnea on exertion, fatigue, orthopnea, and P&D. Paroxysmal nocturnal dyspnea. What does that mean? Wakes the patient up out of a dead sleep short of breath. Okay? Those are signs and symptoms. Orthopnea and P&D are signs and symptoms of left-sided heart failure. So this is a person, by the time they start being symptomatic, they have left-sided heart failure to some degree. Might be a diastolic murmur, could possibly also see a widened pulse pressure. If you remember that from a health assessment or from the very beginning in fundamentals, that's the difference between your systolic and your diastolic blood pressures. Will get very wide. Okay? So you'll have a systolic that's really high and a diastolic that's really low. Okay? Don't worry about Corrigan's pulse. We're not going to talk about that. So our diagnostic test, echo with Doppler. Okay? Typically they're going to do a series of these. We're going to do the initial one for baseline, and they're going to do one like every couple of months, 3 months. I think the book says 4 to 6 months. If the patient is symptomatic, they'll do them more frequently. And then if they're not symptomatic, then I think the newest recommendation is once a year, but I think your book says every 2 to 3 years if they're not symptomatic. Okay? So for testing purposes, we're going to go with what the book says. For practice in real life, you probably might, going to see something different. But for testing purposes in this class, we always go with what the book says, unless I specify to you otherwise. So echo, TEE, of course EKG for dysrhythmias, because remember, whenever we're talking about the left ventricle, we're irritating that left ventricle. It can produce left ventricular dysrhythmia. So that would be something that you would also want to be aware of. So EKG, and then heart cath to actually look at that chamber, see how big it is, and see what the cardiac output is. Medical management, activity restriction, especially if they have a lot of dyspnea with exertion. Avoid physical exertion, anything again that's going to increase oxygen demand, increase cardiac output. The heart's going to have a very hard time keeping up with. Treatment of dysrhythmia, treatment of those ventricular dysrhythmias and CHF symptoms. So calcium channel blockers, ACE inhibitors, afterload reduction, vasodilation. Also, the calcium channel blockers are going to, and ACE inhibitors too, they're going to decrease the pulmonary vascular resistance. Because remember, we have left-sided heart failure, which means we're affecting the lungs. So we're going to reduce that pulmonary resistance and the workload of the left ventricle. The treatment of choice is surgical repair or replacement, typically replacement. And then the goal is to have this surgery before there is major left ventricular damage. Okay, because remember, once that left ventricle is damaged, once it becomes hypertrophied, you can't get that back. Once it becomes big, fat, and stiff, it's going to stay that way, and it's just not going to pump as effectively. So we really want to catch this, diagnose it, and then repair it before the patient has left ventricular dysfunction. Aortic stenosis, just like with mitral stenosis, it's that stiff valve, stiff gate. It might budge a little bit one direction, budge a little bit the other direction, but for the most part, it's sort of just stuck. It's not fully open and it's not fully closed. It's narrowed. So there is a narrowing and a reduction in blood flow between the left ventricle out into the aorta. Okay? Causes are calcifications, degenerative inflammation, degenerative disease. The aortic stenosis does become very calcified. and the mitral can too, but if they've got a lot of problems with blockages in the heart or poor circulation in the legs, diabetics, hypertension, high cholesterol, the classic three triad, then they are very much at risk for developing calcifications on their aortic leaflets that would make it stenotic. So it can also be congenital in nature, and again, rheumatic heart disease. Any kind of rheumatic infection will actually cause those leaflets to stick together or adhere, causes adhesions. Idiopathic, can be just a flat unknown cause. So one of the things that they'll do is an echo, and they'll look to see if there's anything on those leaflets of that aortic valve. And if it appears to have growth or calcification on it, they call that vegetation. So that's a sign that that valve is becoming stenosed. So again, this narrowing reduces or restricts blood flow out of the left ventricle into the aorta, which means the left ventricle has to pump, it has to contract with more force to get the blood out. So it has to work harder to overcome this narrowing. And over time, that leads to left ventricular hypertrophy. Now, this is not necessarily backflow of blood. It's not that it dilates and it has to accommodate extra blood. It just takes more force to pump the blood out of the left ventricle. So it can lead to left ventricular hypertrophy. It'll thicken and eventually left-sided heart failure as that left ventricle begins to fail. So cardiac output drops and their ejection fraction will be reduced and their cardiac output will be less. So again, usually asymptomatic at first. Usually don't catch anything until signs of left-sided heart failure, dyspnea on exertion, orthopnea, PND. In severe cases, they can develop angina, pulmonary edema because of the oxygen demand and the lack of meeting that demand. With aortic stenosis, there will be a very loud systolic murmur over the aortic area, rough, vibrating murmur, a very low but a very rough murmur over the apex and up to the carotids. So some very unique sounds. Okay, you might also hear that S4 extra sound when you're auscultating heart tones. Okay, but a very loud, and the volume or the grade of the murmur is how we say it. A grade 1 is a very minor murmur, all the way up to like a grade 5, which is audible without a stethoscope. So it depends on the severity of the stenosis as to how loud the murmur is going to be. Okay. Diagnosis through echo with Doppler flow study, because we want to look at that blood flow and see how much it is impaired getting out of the ventricle. 12 lead EKG, of course, because with left ventricular dysfunction, left ventricular failure, left ventricular hypertrophy, that leads to ventricular dysrhythmias. Heart cath is indicated, of course, to look firsthand at that chamber and see what is the cardiac output, how much is it hypertrophied, how narrow is that valve, and then of course surgical repair is the treatment of choice. So medical management is going to be dysrhythmia medications for ventricular dysrhythmias and heart failure management, and then surgical repair of that aortic valve if it's stenotic. All right, so our responsibility, nursing management, for people with valvular disorders, and this is all types of valve disorder, not just, we just got through talking about aortic stenosis, but we're shifting gears, and we're talking about our responsibility as the nurse for a patient, no matter what kind of valve disorder they have. Okay? So what do we always do first? Assess. So our physical assessment findings are first, priority-wise. Look at their vital signs, heart rate, blood pressure. That's going to give you some indication of cardiac output. You're going to listen to heart and lung sounds. You're listening for murmurs. You're going to listen for crackles. You're going to be listening for clues that will indicate possible left-sided failure, possible right-sided heart failure. You're looking at signs and symptoms or signs of perfusion, cap refill. You're listening, do they have a dry cough? Do they have a wet cough? Do they have problems with dizziness and syncope when they get up? Do they have palpitations? Or do they have very forceful beats? Do they have arrhythmias? Are they atrial in nature? Are they ventricular in nature? Are they having some intermittent AFib and aflutter? Are they throwing frequent PVCs? You're just looking for little clues to kind of lead you. Because when you look at that patient, there's not going to be some big neon sign over their head blinking off and on that says mitral regurg, mitral regurg. It's not like that. You have to look at that patient and use your physical assessment findings as your clues. Okay? So after your assessment, very thorough assessment, our next responsibility is education. Teaching that patient what's going on, the nature of their disease process, what exactly is their specific problem, what's the treatment plan, what options, what can we give them to reduce their risk. We need to teach them about prevention of endocarditis, which would be prophylactic antibiotics, especially when going to the dentist. We need to teach them about taking their medications regularly and what they're for, side effects of those medications. They've got to be compliant. We need to teach them about their diseased valve and how bacteria, this is why they need prophylactic antibiotics, because they have that diseased valve, bacteria really like to go live on it. That's vegetation. So if the valve is diseased, bacteria actually have an affinity for that diseased valve, and it will go camp out on there and start to grow, and that's what actually leads to the endocarditis. So that's why prophylactic antibiotics are so important. We need to teach them about signs and symptoms of right-sided heart failure or left-sided heart failure, things that they need to watch for, like orthopnea and P&D, or peripheral edema and weight gain. We need to teach them things about doing daily weight, same time, same clothes, same scale, every day, and track their weight. Significant weight gain overnight is fluid, so that would be very important if you were dealing with somebody that had right-sided heart failure. We need to teach about rest and activity restrictions and modifying their functional patterns so that they can get, ADLs accomplished without tiring themselves out. So just all that basic stuff, okay? A lot of teaching, signs and symptoms to report. They need to be very well aware or acquainted with their typical symptoms. And then whenever that typical symptom changes, or if a new symptom develops, they need to report it, because that could be significant. That could indicate a worsening of that valve problem. Okay, so valve replacement procedure we're going to talk about is just complete replacement of the valve. Um, it is done in a very similar fashion to bypass surgery, to the coronary artery bypass grafting. It is a sternal incision. They have to actually physically crack the chest, put the patient on cardiopulmonary bypass, rest the heart, and go into the heart, cut out the diseased valve, and replace it with an alternate valve. So the two different types of valves that can be used, or most commonly used, there's a mechanical or a metal valve, and then there are tissue valves, biologic or tissue valves, which are made from either a cow, they're either taken from a cow or taken from a pig, or there are some autografts. We're not really going to talk about autografts that much. The two most common are bovine, which is a cow valve, and porcine, which is a pig valve. Porcine is the most common. Why? Because cow valves and pig valves are roughly the same size as human valves, and they're tissue, so they can easily be sewn in to the patient's existing area inside the heart, and they usually fit very well. Okay? So why would we do one over the other? Okay? Mechanical valves, they're made out of metal. They last. They're almost indestructible. They last longer. They don't deteriorate or degrade. They don't get infected as easily, but they're metal, so the body does recognize it somewhat as a foreign object. It doesn't reject it, but it does tend to want to clot against that valve. So a patient who gets a mechanical valve has to have lifelong anticoagulant therapy. They'll be on Coumadin forever or something. Mechanical valves also click. They often make an audible clicking noise. So the patient initially, there's a little bit of coping and adjusting because they can hear that click internally. Actually, that click can be heard audibly if you stand close enough to them. So, and I mean without a stethoscope, you can actually stand next to a patient who has a mechanical valve, and it's usually within the first couple of months after they've had it put in. You can stand beside them, and sometimes you can hear that valve clicking. Now, over time, that'll go away, but initially, it can be audible without a stethoscope. But so advantages of a mechanical valve, it lasts longer. So if the patient is very young and they need to have a valve replaced for some reason, let's say it's a congenital issue, you know, as an adult, now they don't put mechanical valves in kids because as the child grows, that mechanical valve won't grow, where tissue valves will somewhat grow and accommodate. But as an adult, let's say a 20, 30-year-old has to have a valve replacement, they probably are going to use a mechanical valve because it's going to last longer. If they use a tissue valve, then there is the possibility that when that person is in their 60s, 50s, 60s, later in life, that they may have to have another valve put in. So tissue valves, again, can either be bovine, which is cow, or porcine, which is pig. Those are xenografts. Or there can be a homograph, which is a human valve that is used from a donor. Okay? These type valves do not require anticoagulation, but they're tissue. They don't last as long. Okay? So when if you run across a patient in clinical this semester that has a valve, you want to know, first off, is it mechanical or is it tissue? And then, depending on what you find, it would just be interesting to correlate how old were they when they got their valve. Sometimes patients they can't take anticoagulation. It might be a case where we're afraid that the patient won't be compliant. So it would be best to give them a tissue valve. There's various reasons why they would choose one or the other. In general, the type of valve is determined by the age of the patient and then the degree that we expect them to be compliant with their anticoagulants. Nursing management for valve surgery. Pre and post-op care is basically the same as with heart surgery. Okay, very, very thorough preoperative assessment, and of course echo with Doppler flow studies to have very clear documentation of the extent of the disease of the valve, and then probably heart cath too, direct visualization. Patient education is exactly the same as what you would do for bypass surgery. So go back and review that. Post-op care, initially it's the same as bypass surgery. It's the same wound, same incision care. Still going to have, probably going to have chest tubes just like with bypass surgery. Pain control issues, nutrition, healing from that sternal incision. So all of that same teaching that you would do for CABG surgery, go back again and brush up on the postoperative stuff. And then specifics to the valve is medication teaching, which is going to be the anticoagulation if it's mechanical. And then infection prevention. They've got to have prophylactic antibiotics for anything that's invasive. Dental work, surgeries, even a lot of times these days they're going to give it for an upper GI, a lower GI, anything where there is a risk of infection, because valve patients, artificial valves, are so much more prone to collect bacteria. And then of course there's a lot of psychosocial, the coping with if it is a mechanical valve and they can hear it, and there's also the psychosocial or coping aspect of knowing that you have an artificial device implanted in you. Even if it's a tissue valve, it's foreign, and sometimes patients have a hard time coping with the fact that they have a foreign substance implanted in them. So, don't dismiss that coping. Okay, so next we're going to talk about cardiomyopathies. Cardiomyopathy is really kind of a global term that is used to refer to progressive impairment of heart muscle that eventually leads to a reduction in cardiac output in heart failure. And it can result, if cardiomyopathy goes far enough and is severe enough, it can result in not just heart failure but sudden death, dysrhythmias. Kind of depends on the type of cardiomyopathy that you're talking about. There are many different types, as you can see on here. Dilated, hypertrophic, and restrictive are probably the most common that you're going to see. Arrhythmogenic just means it's associated with a dysrhythmia, usually a ventricular dysrhythmia. It could be that the patient experienced an arrhythmia and it caused muscle damage globally, or because the muscle itself is so damaged, the patient is prone to ventricular dysrhythmia. With the dilated type, it is the most common. That's just where the chamber becomes enlarged. Now, cardiomyopathy can be associated with a single chamber of the heart. It can be either one of the atria or either one of the ventricles. It can be a side of the heart, as in the right or the left, so that would be both right atria and ventricle or left atrium and ventricle. Or it can be global, meaning all chambers are affected. So when you're in the hospital and you're looking, you see your patient has a diagnosis of cardiomyopathy, you really want to know, is it a left ventricular cardiomyopathy? Is it a left-sided? Is it global? That kind of is going to kind of give you direction about what to expect and what symptoms that you might see in your patient. So dilated, like I said, is most common, and that just means that the chamber, whichever one is involved, is enlarged or stretched. Okay? The hypertrophic type means that that chamber, the walls of that chamber have become thickened, and it's from overuse. Okay? So the dilated type usually happens as a result of pregnancy. Well, it can happen as a result of pregnancy. It can also happen as the result of viral infection. The hypertrophic kind, a lot of times you will see that from hypertension, some genetic disorders that will cause a thickening of the walls of that chamber. The restrictive type is when those chambers become very stiff and the ventricle or the chamber just cannot move, can't pump adequately. So you can see it can be from all kinds of different causes, but generally speaking, regardless of the cause, cardiomyopathy just means that the wall structure or the chamber itself is not functioning the way it should, and that can lead to severe heart failure. It can also produce lethal dysrhythmias and death. Okay? And that's all types. Doesn't matter the cause. They can all lead to severe heart failure, lethal dysrhythmia, and death. So assessment and diagnostics related to cardiomyopathy, typically the symptoms progress as the disease gets worse. So if it's a very mild cardiomyopathy where there's not much impairment, the patient's symptoms are going to be milder or in some cases not even noticeable. Really the symptoms depend on the degree of heart failure that the patient is experiencing. So at first you're going to see signs and symptoms of heart failure, either right or left side failure depending on which chamber is involved. Eventually, as it progresses, if it's left-sided, they're going to get those respiratory symptoms, PND, orthopnea, maybe wet lung sounds, some murmurs. If it's right-sided, then they're going to end up with peripheral fluid retention, peripheral edema, weight gain. So you really need to be solid on your signs and symptoms associated with right-sided heart failure and left-sided heart failure, because that's really going to be what you see first. Diagnosis, in order to diagnose cardiomyopathy, you've got to combine a patient history, a very thorough history of other things that can cause heart failure. So you need to go back and think about everything we've talked about through this semester. What are those things that can cause heart failure? Prolonged untreated hypertension, MI, any of the normal things that we've already discussed. So you have to do a thorough history and rule out any of those other causes. Then they will combine results of an echo, chest x-ray, and then invasive cardiac cath testing to determine the extent where the involvement is, what chamber the involvement is in. They'll do echo with Doppler study to look at the flow, and they will also they're looking for flow between the chambers, and they're also looking to see if there's any valve impairment. If the chambers are greatly enlarged, then that can actually cause valve impairment, as opposed to before how I was talking about having a bad valve that leads to a hypertrophied chamber. So it's kind of a two-way street. If the valve is the problem, then it can lead to cardiomyopathy. But if the patient develops a cardiomyopathy for another reason, it can cause valve dysfunction. So try not to be confused about that. So echo with Doppler flow studies to see the valves and the flow. EKG, we're looking for dysrhythmia. We're looking for ventricular dysrhythmias in particular because those are the more severe kind. They will use chest x-ray. You can actually see on a chest x-ray, you can see an outline of the heart. It's called the cardiac silhouette. And patients who have cardiomyopathy have an enlarged silhouette, and so that gives us an indication that the heart is bigger than it should be. Of course, with echo, they can actually measure too with pictures, and they can see that it's bigger. And then with cardiac cath, they'll actually go in and they'll measure those pressures invasively. They'll look at each chamber size. They can determine the ejection fraction. And then they also can shoot the coronaries and determine whether or not it was a blockage or an MI that actually caused this cardiomyopathy to develop. The only true treatment for a very symptomatic cardiomyopathy is heart transplant. Once those chambers, once the walls of those chambers are either stretched out too far, that would be like your the elastic in your pantyhose or in your socks getting shot. Once it's stretched, you can never get it back to normal. If it's hypertrophic, where the walls are very stiff, rigid, they don't contract like they're supposed to, then once it's like that, there's no turning it around. You can use medicine to augment and help it be better, but that stiffness or that stretched out part is never going to resolve. So really the only true treatment, permanent lasting treatment, is heart transplant. All other treatments, medications, things like that, are aimed at managing symptoms and improving cardiac output. Well, that takes us into medical management, so we have to know the type and the cause so that we know what medicines to use and to expect. The goal is to aimed at correcting heart failure if it's right or left side, so that's really going to direct the type of medical management that you see. Things like low sodium diet, beta blockers, obviously, to improve pump function, rest and exercise balance. If they have trouble with dysrhythmias, you're going to see antiarrhythmic medications, possibly a pacemaker or implanted defibrillator if the patient is having a lot of trouble, if they're having like a left ventricular cardiomyopathy and they are very prone to lethal VFib, VTAC, dysrhythmic events, then they will put in an ICD, and that patient will actually have a very impressive EKG where their QRSs are very wide and just kind of bizarre looking, and that's normal for them. They will anticoagulate these patients. They routinely are on either a full dose aspirin or even something like Plavix or Eliquis if needed, because if you're talking about a dilated cardiomyopathy, then you've got pooling, which would promote clotting, or could promote clotting. And then if it's hypertrophic, we just have that reduced pump function, so there might actually be some residual blood in the chambers. So either way, you're at risk for clot and embolus. Of course, fluid restriction, if the patient is extremely symptomatic, if it's a bad right-sided failure and they're retaining, you're going to be seeing some fluid restrictions. As we are treating the patient for their symptoms, there are some things that the patient some surgical procedures that the patient might be a candidate for that are what we call a bridge to transplant, meaning they're either on the transplant list and they're waiting and there just hasn't been a match found yet, or maybe they're not symptomatic enough to be very high on the transplant list, because at least in Louisiana the transplant list is based on acuity. So there are a few surgical interventions that can be done to help to treat the patient, not just their symptoms but the actual dysfunction of the heart itself. One of them is called an LV reduction, or a left ventricular reduction, where they actually will go in, similar procedure to a cabbage, but they, instead of bypassing those coronary arteries, they actually go in and will just resect out a wedge or a section of the ventricle, the left ventricle, that is enlarged or is hypertrophic. Now, obviously, if it's a very large part of the left ventricle, you can't resect the whole thing. So the LV reduction is really aimed for cardiomyopathies that are isolated to one small area. Okay? And then, of course, transplant, I talked about that. Assist devices and artificial hearts are also bridges to transplant, meaning that they are mechanisms that are either implanted into the heart, actually physically similar. It's kind of similar to bypass, meaning that it's not implanted in the chest like a pacemaker is, but it's actually embedded into the heart, and they pump. They're actual mechanical pumps. That's an assist device or an artificial heart, and they actually contract with the heart and augment contraction and cardiac output. Typically, the assist devices are left ventricular assist devices, or LVADs is what they're called. A left ventricular assist device, and it's implanted. The patient typically is in the hospital. I don't know what the latest criteria is. I don't know if they can go home with them. But the patient becomes dependent on it, because as the machine augments cardiac output, the muscle, because it's so weak, it actually becomes even more dependent on that LVAD device. And so once they go on an LVAD, they don't come off of it usually. It's something that they're on until they either get a transplant or they die. So it's kind of like the last-ditch effort before, to try to get them some relief and improved cardiac output to transplant. All right, moving into infectious diseases of the heart. Another kind of a new area, new topic here. Any layer of the heart can be affected by infection. Okay, we talked earlier about the endocardium, myocardium, and epicardium, and then we have the pericardial sac. So you've really got 4 places there that can be affected by infection. They're all named based on the layer of the heart that's involved. So if it's the endocardium, it's endocarditis, myocardium, myocarditis, and so on. Itis meaning inflammation and infection. Okay, so we make a diagnosis based on the patient's report of symptoms, and then an echo to look at the structures and see if they are inflamed or limited in any way. The best treatment for infectious diseases in general is prevention. So you really need to think about, we've talked about valve disorders, we've talked about heart failure and cardiomyopathies, patients that are at risk for infection in a layer of the heart. Okay, anybody that has a weakened heart muscle or has been exposed in a certain way, they could be prone to develop an infection in one of the layers. Okay, and then treatment is antimicrobial therapy if it's bacterial in nature. If it's viral, of course, there's really not any way to treat a viral infection other than symptomatic treatment. And that's where actually where a lot of the cardiomyopathies can come from, are viral and bacterial infections. So in my experience working years ago when we worked with cardiomyopathy patients, many of them developed a bacterial endocarditis or a viral endocarditis for some reason. It could be that they traveled out of the country and water exposure to water that has parasites and bacteria and things in it. I did have a guy one time that was a missionary, and he had traveled to Africa, and he picked up a virus down there, and that virus actually settled and gave him in the heart and gave him a viral endocarditis, which led to a viral cardiomyopathy. So not all cardiomyopathies are the result of ischemic events. Sometimes it's the result of an infection that has damaged the heart so much that it created a cardiomyopathy. Okay. So the first one we're going to talk about is rheumatic endocarditis. It's most common in kids. Y'all might have talked about it in peds. And it's generally associated with group A strep or strep A pharyngitis. So lot of little kids can get pharyngitis, and the A strep is always the bad one. That's why it's so important that when your kid has strep throat, that you really want to have it checked out, because if it's the strep throat that produces rheumatic fever, then that can lead, if it's not treated appropriately, or even if it is treated appropriately for, often for unknown reasons, that strep A in rheumatic fever will actually settle on the heart and develop a rheumatic endocarditis. So that's where that comes from. Infective endocarditis is another type of infectious endocarditis that's again, a bacteria that just kind of lodges in the inner layer of the heart. Typically you see this infective endocarditis in prosthetic valves, and then people who have structural defects of the heart itself. That might be a congenital structural defect. Those can be kids or adults. I mean, obviously adults usually have valves. Sometimes children have valve replacements too. But the structural defects can be children or adults as well. And also you will see a lot of times, commonly you'll see infective endocarditis with drug abusers. Okay? And then other people who have long-term invasive procedures. This is where the push for catheter-associated infections in the hospital, prevention of catheter-associated bloodstream infections, there is such a push for that because the end result is an infective endocarditis. Okay? Long-term hospitalized patients, rehab, long-term vent-dependent patients at Promise or Life Care. I think all of you have been in the hospital long enough now to have seen patients that have moved from the acute hospital setting to long-term care. So, invasive lines, invasive catheters, a Foley, a PICC line, a triple lumen, any kind of invasive triple lumen catheter, anything that's left in a patient for a long period of time, obviously, is direct access for bacteria to enter the body. In these patients, if they have these lines in place for long enough, they can actually not just become septic, but they can actually develop an endocarditis because of it, and then that can eventually lead to cardiomyopathy and then other issues as well. So that's the push for Joint Commission and the catheter-associated infection prevention. Another type of infection I want to talk about is pericarditis. That's inflammation of the pericardial sac, or the layer around the heart that is supposed to be there for a small amount of fluid to reduce friction with every contraction. Okay, so normal amount of fluid inside the pericardial sac is about, I think your book talks about 15 to 20, 10 to 15, no more than 20 mils of fluid. And it's the same principle that we talked about with pleural effusions, that there is a normal amount of fluid in that space that it acts as a cushion. But in the event of inflammation in the pericardial sac, the layers can either A, stick together to where the fluid, there's so much inflammation that the fluid is not able to do its job, and as a buffer or a cushion, and so those layers are inflamed and swollen, and they actually adhere together. And when the layers stick together, it becomes restrictive or constrictive in nature, and it can reduce cardiac output. It can actually create a type of tamponade and keep the heart from pumping the way it should. And then another type of pericarditis or problem that you might see is where the pericardial sac actually fills up with too much fluid. It could be serous fluid, it can be blood, it can be infected fluid with like pus in it. So it can be any of those things or a combination of those things. But the pericardium, it fills up with fluid, and so all of that extra fluid puts pressure on the heart and is restrictive in nature. So, either way, whether it's the fluid or the layers sticking together, or we've got too much fluid in the space, it really restricts the ability of the heart to contract. Okay, some of the causes might be from injury, a blunt trauma, chest wall trauma. It can be from viral illnesses, can be from bacterial illnesses, can be from surgeries. It's not uncommon to see pericarditis after heart surgery because we have gone into the chest, we've made an incision, and then we had to open up the pericardial sac to actually get to the heart to do the bypasses. Same with valve surgeries. So, you can see it develop after that. And you could also see it develop after an acute MI, just from inflammation in the cardiac tissues that could spread out into the pericardium and cause inflammation there. So, symptom-wise, the patient is going to complain of constant chest pain, but it's going to have that worse, it's going to be a little worse on inspiration, so it's going to be chest pain, angina in nature, but it's going to vary with inspiration and expiration, which is not characteristic for angina. So, a lot of times with pericarditis, we end up thinking it's pleuritic in nature first, and then they'll rule out pleurisy, and they'll realize that it's pericarditis. And then that classic finding, very characteristic finding on auscultation of heart sounds is a friction rub. So that's kind of the key distinction that'll make them say, oh, this is pericarditis, this is not pleural, okay? If they have a pleural friction rub, then you can hear it laterally and in the bases or up top around the apices of the lungs. But if it's a cardiac, if it's pericarditis and it's a cardiac friction rub, then you're going to hear it in the areas where you auscultate for heart sounds. So it's a location difference, okay? A friction rub is a friction rub, but it's where do you hear it? It's the location that you hear it that is really the diagnostic characteristic. Medical management is based on patients' report of symptoms, their history. Have they been ill? You're going to want to know, have they had a cold? Have they had strep throat? Have they had surgery recently? Just their report of the symptoms when they started and anything that you can correlate to the cause. Echo, of course, will be used to diagnose. We're looking at the the heart structures, the valve structures, the chambers, and then they're looking at the pericardial sac. They can measure the fluid that's in the pericardium or the absence of fluid, or if things look like they're stuck together, they're going to see all that on echo. Once they identify the causative agent, then the treatment will be aimed at that. If it's infectious in nature, bacterial, they'll use antibiotics. If it's viral in nature, then it's really just symptomatic relief. Analgesics, NSAIDs to help with fever and feeling better, steroids to reduce inflammation. Of course, our priority as nurses is to monitor that patient, assess that patient for signs of cardiac tamponade, and that would be a narrowing pulse pressure. If you're in the hospital, patients on the monitor, where you're doing blood pressures frequently, their pulse pressure is going to become narrow with tamponade. Other signs of tamponade are pain, decreasing cardiac output, poor signs of perfusion, and mental status changes and things that go along with that. So the treatment of choice for pericarditis is called a pericardiocentesis. That is the same as a thoracentesis or a paracentesis, except, it's a sharp needle that we are actually putting into the pericardium instead of, lung pleural space or abdomen. So pericardiocentesis, we're drawing the fluid off with a needle, typically done under fluoroscopy so they can see exactly where they're going. Now think about it. We're putting a sharp needle really close to the heart. What if I hit the heart? What if I stimulate, a ventricular arrhythmia? What if I puncture the heart and cause bleeding? What if I tear the heart, and lead to an MI? There's all kinds of complications that can result from a pericardiocentesis. Arrhythmia, MI, puncture, just a lot of problems with pericardiocentesis if it's not done correctly. It can be done under fluoro. It can be done very well and be a fantastic treatment. But you just need to really be aware of your patient who's having a pericardiocentesis of what to assess for after the fact. If pericardiocentesis doesn't work, or they can't do it, or if they do a pericardiocentesis and then the fluid returns, builds up again, then the treatment is then a pericardial window where they will actually go in surgically. It is similar to CABG, where they crack the chest. They don't always have to put the patient on bypass to do a pericardial window, but they will go in and they will actually resect out a piece of the pericardium, whatever area is involved. They will remove the part of the pericardium that's causing the problem, and or they will drain the fluid and then they will scar those layers down and seal them off so that it can't refill with fluid again. So in essence, a pericardial window is somewhat similar to the pleurodesis that I talked about with pulmonary, with pleural effusions. So the pericardial window would be an equivalent type treatment for the heart, okay, for a recurrent